Okay, so my group had emotional contagion. My article focused on the client and therapist emotions during like events or tragedies that happened. One example was 9/11. That's just an example of a tragedy that where a client and a therapist could share emotions. So shared trauma was the topic. On the therapist end, they have multiple responses to trauma. These responses include emotional reactivity, which is where they have more or stronger feelings towards the event or unexpected emotions or reactions. There's fear and anxiety. This is any personal emotions or feelings as a result of trauma that inhibits or distracts the therapist. Fatigue, which is emotional or physical exhaustion. Sadness, grief, depression. This is obviously feeling low. This is when they use their time to mourn. The absence from clinical practice. This is either for personal need or professional demands, but this in itself, where leave or absence could help with your stress, it also increase stress in your line of clinical work, being that you're absent from your clients and stuff. There's intrusive imagery, anything that can trigger emotions from the traumatic event. I thought this is sort of related to PTSD, but isn't. So like sounds or images can trigger emotions. And in the example of the 9/11, if you hear a person were to hear a plane passing over, that could trigger intrusive imagery. All these emotions can influence professional work and must be recognized and treated accordingly. So then on the client's end, as a result of a traumatic event, clients may need additional sessions from therapists, whether in person or via telephone, however they need it. This can increase stress in the life of the worker when they are trying to manage personal feelings from a traumatic event, whether the event is shared or personal. Uh, with this, there are boundary shifts and issues between the client and therapist. The clients may ask therapists about their well being, at which this point the therapist has to make a decision as to whether they want to disclose this to their client. In turn, the client has to respond to their therapist's loss of control or safety. This is called transference. Uh, Opposite of transference is counter transference, which is where the therapist may feel discomfort with sharing such details to client, such as personal experience or feelings with the client who has been through the same or similar tragedy. When there is tragedy or traumatic events, during this time of crisis, many psychologists may be seen as trauma experts and can be asked to respond, give information and advice to those experiencing trauma. The psychologist's own experience of the tragedy may decrease their feeling of competence and self confidence in their work, and this will make them question their own ability. Professional demands are increased, which causes more stress on top of the personal distress. When it comes to vulnerability, there are three levels of it. There's direct or primary traumatization, which is the direct effects of exposure to traumatic events as perceived and experienced by self. There is secondary traumatization, the effects of experiencing the traumatization of others whom self loves and for whom one may feel responsible. So that's like, no, that sounded weird coming out. It's pretty much like a family member going through something. So that's secondary trauma. Like you feel for that person because you love that person, or you maybe feel responsible for them going through that. There is vicarious traumatization, which is the transformation of one's inner self as a result of empathetic engagement with traumatized clients in the context of a helping relationship. When it comes to these levels, one can experience all of them or just a few of them. There's only three of them. Digging deeper into vicarious traumatization, a therapist's vulnerability to vicarious traumatization is influenced by the interaction between self, the therapist, and his or her client or his or her current clinical work. Some factors that contribute to this include that each therapist has a unique personal response to an event that is deterred by personal dynamics and their style of defense to tragedies. So pretty much their own. That's pretty much saying like their own coping. So everybody has their own way they cope with things. The current life circumstances, as well as the proximity and personal connection to the events and people involved in it. Again, that's kind of like secondary traumatization if they know somebody who was in it or they were in it themselves, that can affect them. His or her personal empathetic engagement with each client's unique experience of the tragedy. An example of this, just digging deeper into that, that would be things such as like when a client reports anxiety that oneself had not yet thought of. So, say you and a client both went through something, and that client had a different reaction to feeling to it, and they tell you, and it's like boom, it hits you like on top of your own personal stress. Now with the client they share with you, you feel as well. The client can describe a known or imagined experience of a particular survivor or victim that was unknown to one beforehand. So they could put you in on something that you didn't even know had happened in that event, which could mess you up even more. And also, when a client uses coping strategies that conflict with one's own defense or coincide with self anxiety. So, like I said, everybody has their own coping strategies, but in this case, a coping strategy of a client could mess with a therapist. In these circumstances, one's emotional stress and vulnerability to vigorous traumatization increases. So, and that's it on my article and emotional contagion.